Welcome, everyone. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation, Hodgkin Lymphoma, Progress in Understanding and Treatment. In this session, Dr. Mary-Margaret Keating, a hematologist at the QEII Health Sciences Center in Halifax, Nova Scotia, will provide an overview of the approach to Hodgkin lymphoma and provide updates on recent developments in the management of this disease. Before we begin, let me introduce myself. My name is Paul O'Connell. I am the Research Program Lead at the Leukemia and Lymphoma Society of Canada, and I will be the moderator of this event. We invite you to type your questions and comments into the Q&A box of your Zoom webinar panel throughout the presentation. An LLSC staff member will monitor the questions, and I will read some of your questions aloud at the end of the presentation. Due to the large number of questions and participants and limited time, we may not be able to answer all of your questions. Also note that Dr. Keating cannot answer specific questions about a person's health status or history. If we do not get to your question during the live presentation, a community service lead will contact you in the coming days. Today's presentation will be recorded, therefore you can re-watch it again on our website. Next slide, please. Are you looking for specific programs or resources but not sure where to find them? We are here to help. You can connect with a community services lead in your area and receive personalized assistance and get connected to resources in your region. Reach out to us by calling toll-free 1-833-222-4884. Next slide, please. We invite you to visit our website, bloodcancers.ca. Our goal is to better serve the community and offer an improved experience. Slide. On our website, you will find tailored information and resources, including those specific to Hodgkin lymphoma. These include recorded webcasts, podcasts, fact sheets, animated videos, and much more. Slide. Did you know that LLSC has an app where you can track your symptoms, side effects, and much more? Download the free Health Manager app to help better manage your blood cancer diagnosis. It includes medication reminders, meal planners, medication and side effect trackers, plus shared caregiver access. This app is available for Apple or Android devices. Slide. We also offer programs that can help connect you with other members of the blood cancer community. We offer a peer support program where you can connect one-on-one with a peer volunteer and virtual support groups. Connect with a community services lead in your area to learn more. Slide, please. It's now time to introduce today's speaker. Dr. Mary-Margaret Keating is a hematologist and assistant professor of medicine in the Division of Hematology at the QEII Health Sciences Center in Halifax, Nova Scotia. She has a clinical focus in lymphoma and is involved in selecting and overseeing clinical trials for this disease area. She earned a master's in medical education and has a passion for teaching medical students, residents, and patients. She is the program director for the Hematology Residency Training Program and is involved in developing the Dalhousie Medical School Curriculum. Thank you for being with us here today.
Thanks so much for that, Paul. And just so Paul and Pascal know, it looks like I'm logged in twice. It's actually my clinic nurse who wanted to listen to this, so I hope it's okay. She's logged in with a QEII Center. I realized that after the fact, it came in differently than everyone else. So thank you for inviting me to do this. I said it's been a couple of years since I've done a talk like this, and it's always interesting to look back at my old slides and see all the new drugs we now have available compared with the last time I did it in 2018. So we're going to be talking about Hodgkin lymphoma today, understanding that this is going to be a diverse population listening to me talk today. And it's hard as the speaker to know exactly how much detail people already know or don't know. So the time for questions at the end will be helpful, I think, in case people need more detail in certain areas. This is a big topic to talk about, of course. I do have disclosures here, just some work that I do for some drug companies for helping with drug approvals and otherwise. So I think important to disclose those things. Today's learning objectives is to review some basics about what a normal lymphatic system is, some symptoms of lymphoma, how we make a diagnosis of Hodgkin lymphoma and know that's what we're dealing with, some essentials that I think every patient should know about their disease, talk about some current drugs available in Hodgkin's, and talk about very briefly about some clinical trials and new drug development, again, within the limits of about 40 minutes that we have. So the lymphatic system, we'll just touch on briefly, a confusing organ system because it's not what we usually think of as a heart or a lung, but it's an integrated system throughout our body. It's just this diagram shows. You can see the lymph nodes. There's over 500 lymph nodes in our body, depicted by the little orange dots you see there. They run throughout our body, even more than what is shown there, and they're connected by lymph vessels or lymphatic ducts. And these carry white blood cells, fluid, fats from our bowels throughout our body, and they help integrate in and out of our blood system and organ system. So it's sort of a solid but liquid system that carries a lot of our immune system. So that is a hard concept for people to get over, to get in their heads, that it's almost like another type of vascular system, except for with lymph fluid. Other parts of the lymphatic system include our tonsils, our thymus gland, which is in our chest there, you can see pointed out, our spleen, and our bone marrow is also part of our lymphatic system, which is our blood forming organ. So when we're talking about lymphoma, we're talking about a cancer related to this organ system, the lymphatic system. The bone marrow is part of the lymphatic system, and the bone marrow is constantly producing blood cells, red blood cells that carry oxygen around the body, white blood cells that help fight infection, and platelets that help clot the blood. Lymphocytes that I have outlined in the orange box below are one type of blood cell that are important to help fight infection. And that's the main blood cell we want to focus on when we're talking about lymphoma. So what is lymphoma and why does it occur? When I see patients for the first time, they may know they have lymphoma, but they don't have a good concept of, is that a cancer or not? Or, what type of cancer is this? Again, because just understanding this different organ system, the lymphatic system. So lymphoma, as I mentioned, is a cancer of this lymphatic system of somewhere within these channels and lymph nodes, sometimes with multiple areas involved because they're so interconnected in this organ system. So the cancer cell is actually a type of white blood cell called a lymphocyte. And as you can see from the orange arrow here, this is what a lymphocyte looks like in a cartoon depiction. And all these other blobs of purple cells and red cells are the other type of blood cells made by our bone marrow. Each of these cells can create a different type of blood cancer unrelated to lymphoma. Again, why it's important that you have a clear diagnosis of your type of cancer. So lymphoma's a cancer of the lymphatic system, and the cancer cell is this type of white blood cell called a lymphocyte. But unfortunately, it gets a little bit more complicated than that because there are many different types of lymphoma. Today, we're going to be focusing on Hodgkin lymphoma, but I think the other day they had a talk on non-Hodgkin lymphoma, of which there are many different subtypes, both slow and fast growing. So this is a pretty simplified basic drawing of an approach to categorization of lymphoma, this white blood cell cancer. It's really much more complex with over 70 types of lymphoma, 41 types of B-cell non-Hodgkin lymphoma, 27 types of T-cell and NK cell non-Hodgkin lymphoma, and 4 types of Hodgkin lymphoma. And the diagnosis and categorization of these lymphomas is constantly changing. Every few years, guidelines are updated, differentiating further that maybe this is actually a different type of lymphoma, not the same. The categorization of these diseases is quite complex. Again, today we'll be focusing on Hodgkin lymphoma, which is a more rare type of lymphoma. When you look at NHL, which is non-Hodgkin lymphoma versus Hodgkin lymphoma. Non-Hodgkin lymphoma, the big group, is much more common, about 83% of all lymphomas, whereas Hodgkin, depending on where you get your data, is about 17% of all lymphomas. And there are 4 main types of Hodgkin lymphoma. We're not going to go into a lot of details of the differences between these. Most of them are called nodular sclerosing Hodgkin lymphoma, depicted by the 2/3 blue box here. There's another subtype called mixed cellularity, another subtype called lymphocyte rich, and a rare subtype of Hodgkin called lymphocyte deplete. You may or may not know your subtype of Hodgkin lymphoma. It doesn't make a big difference in treatment. And sometimes we don't even know which subtype it is based on the biopsy size that was done. But there is this categorization to subtype Hodgkin to be aware of. So these are stats from 2017, which are a little bit old, but not changed much. And the predictions for 2023 are much the same. This outlines the different types of cancer and the frequency. The black lines are all what we call solid tumor cancers. Those are generally dealt with by medical oncologists. And the pink ones are all hematologic malignancies or blood cancers, and hematologists / hematologic oncologists deal with these cancers like me. You can see Hodgkin lymphoma here is not very common compared with other blood cancers like myeloma, leukemia, or non-Hodgkin. We see about 1,000 cases in Canada per year of Hodgkin lymphoma. And here in Nova Scotia, where I'm based, we see about 20 to 25 cases per year on average of Hodgkin lymphoma. So it's not that common, which is why it is important to see someone who's familiar with the disease and the different diagnoses and treatment of it, because it is more rare. So this is a common question that we get. Why does Hodgkin occur? Why does lymphoma occur? And unfortunately, we do have the unsatisfactory answer that we don't exactly know, although we know there are some risk factors. This picture shows at the top a cartoon of normal lymphocytes this is a lymph node here. And then you can see the yellow cells on top are normal lymphocytes or normal white blood cells. Something happens to one of those cells, some sort of mutation or change within the DNA of that cell that causes it to mutate and change into this funny looking double-eyed cell called a Hodgkin cell, or a Reed-Sternberg cell is the fancy name for a Hodgkin cell. We know there's some association with previously having had mono with developing Hodgkin, but 90% of the population has had mono. So there's more than just that's required to get Hodgkin. Although it's not a familial cancer, a family history of Hodgkin does increase your risk of developing Hodgkin by about 4 to 5 times. But again, it's a rare cancer, so it's still not definite that somebody else in your family will get this disease. If you have a weakened immune system with HIV or you're born with an immune deficiency, your risk of having these mutational changes is higher within your immune system because you already have a disease of that immune system. So it's more likely to make a mistake and develop one of these cancer cells. There are some exposures that are felt to be linked to Hodgkin's, like benzene, but those are not common things people are exposed to. There is a lot of research going on looking at what predisposes patients to lymphoma overall. And actually here in Halifax, we have one of the main physicians in the country who's doing research on inherited hematologic malignancies. So we're hoping to know more about that in the next 5 to 10 years. We certainly know more now than we did when I started working about 10 years ago. So now that we talked a little bit about the background, we'll get into a little bit more of the clinical things, like what type of symptoms you might expect if you have lymphoma. I assume most people or everyone on this call is already diagnosed with lymphoma or has a family member who is, but it's important to be aware of symptoms because you're looking for symptoms for signs of relapse or signs that your cancer may be worsening or anything like that. So it's good to be aware of what your normal is and if something's changing. The most common symptom people present with a new diagnosis of Hodgkin or a relapse of Hodgkin, meaning it comes back after it's in remission, is a painless enlargement of a lymph gland. So we spent some time at the beginning talking about the lymphatic system. The normal role of the lymphatic system is to fight infection. So if we get a dental infection, we might get an enlarged sore lymph gland at the angle of our jaw, like in this picture, which is in the top of the neck. That's the immune system doing its normal job. If people are getting painless, swollen lymph nodes that aren't going away without infection, you have to be thinking about lymphoma or other cancers that can involve lymph glands. And so that's the most common by far reason people might present. Places you can feel lymph glands would be the neck, the armpits, the groin, most commonly. And again, I put this picture up here again to relook so you can see all the superficial areas where lymph nodes are in the neck, both armpits, and in the groin region are the easiest place for your doctor to feel a lymph gland if it's enlarged. Any of the deep lymph nodes you need a CAT scan to see. Some other symptoms of lymphoma could be something that we call B symptoms. That means fevers, greater than 10% of your body weight loss within 6 months, or drenching night sweats. And these drenching night sweats are really significantly abnormal, like soaking through the bedclothes, needing to change your pajamas regularly, often associated with weight loss and fevers. So usually if you have Hodgkin's, we label you as having a stage like 1A, meaning no B symptoms, or say 2B, meaning stage 2 with B symptoms. So that symptom is important for us to denote as the doctor. Low blood counts can be present if there's bone marrow involvement of your lymphoma. Bone marrow being part of the lymphatic system, these cancers can be in the marrow. It's not common to see Hodgkin lymphoma in the marrow. So that is rare with this diagnosis. But can occur. Blood work changes can occur. We always check liver and kidney function, because if there's a big lymph node in the abdomen, it can block the kidney or block the liver. We can see abnormalities there. Pain from other organ involvement. So although the enlarged lymph glands themselves don't cause pain, if they start pushing on things, if they push on a muscle or push on a nerve, they can start causing discomfort. So we certainly pay close attention to persistent pain that isn't going away. Rare Hodgkin symptoms would include diffusely itchy skin or rash, pain in lymph nodes after drinking alcohol, or a high calcium level. So when I see a new patient with Hodgkin or other lymphoma, I always have, usually I used to write it out all the time, but now I have a pre-typed out form that I fill out for them. Essentials that I really think all patients need to know about their own cancer. One, are we clear on a diagnosis? What's the stage? What's the prognosis? Are we expecting to cure this? Are we expecting to treat it for remission, but know it will come back in the future? What treatment is being recommended? The pros and cons of that, and potential side effects of treatment, as well as the follow-up plan. So I think these are things that everyone should have a fairly good idea about with their disease. Again, some people wanting to know a lot more detail about prognosis, and other people not wanting numbers or anything specific, just wanting to know that they have a chance to be cured. So I do ask patients how much they want to know. So the first thing we have to do is make sure we have a clear diagnosis. And people often say, the first thing they ask me is this Hodgkin or non-Hodgkin, and how can you tell the difference, or what is the difference? The main difference is how they look under the microscope. They're different types of lymphocyte cancer. They're different types of white blood cell cancer, and they look completely different under the microscope, although they are both cancers of the lymphatic system. How these types of cancer grow can be a little bit different. Their clinical features can be very similar, though. They both present with enlarged lymph glands, potential blood work changes, and the prognosis and treatment of Hodgkin versus non-Hodgkin can vary. And so definitely we always have to start with, what does this look like under the microscope? And are we certain that we have a clear diagnosis from the tissue that was taken? So the most important thing is making the correct diagnosis and having a good biopsy of the tissue. So in this picture on the left, there's an example here showing a needle biopsy of a lymph node, which would be a smaller biopsy. And on the right, you could get a surgeon, often an ear, nose, throat surgeon, if it's a neck biopsy, to take a piece of one of those lymph nodes. Unfortunately, the lymph nodes are not green in your body, so it is not that easy for the surgeons to find them, because they look the same color as the other tissue, but easy to see in this picture as the lymph nodes are green depicted there. So many of you have probably had a biopsy before. Some of you may have had 2 or 3 biopsies and may be wondering, well, why can't they figure out what this is? Why do they keep needing to biopsy me? There are many different types of biopsies that can be done to help, or 2 main ones that can be done to help diagnose Hodgkin or other types of lymphoma. The first one is called an excisional biopsy. And as the hematologist and the lab doctor, the hematopathologist, that's our favorite type to have, because it gives us the most information. It does require a surgeon to have this type of biopsy done. It's best for easy to reach lymph nodes, like in your neck or armpit or groin. It does remove all or part of a major lymph gland that is abnormal. and it gives the pathologist a good amount of tissue to look at. It's important to differentiate the different types of lymphoma. This picture, I'm just going to move myself here, shows a bigger piece of tissue that is a piece of a lymph node cross-sectionally cut. This lymph node actually shows two different types of lymphoma. Not that I expect you to see these small pictures, but in the red area, it's something called diffuse large B-cell lymphoma. And in the blue area, it actually is Hodgkin lymphoma. So this patient had two types of lymphoma in the same lymph node biopsy, which I've seen before. This is not rare, it's not super common, but the better piece of tissue, like if we had done a needle biopsy of this, we may have gone right in between or only seen one or the other. That type of larger tissue is helpful to know really what's going on. A core needle biopsy is commonly done for lymphoma as well. This is a very reasonable type of biopsy to do. You can see the different size and shape of the tissue because this is more, and of course, this is not to scale. This is actually quite small. It's not this big. I have it blown up, but these are the core needle samples of a biopsy. And these ones are good for reaching lymph nodes that are deep in your abdomen or chest. These are often done by radiologists who can look at the lymph node on a scan at the same time they put the needle in it. The main pros about this type of biopsy is it's very non-invasive, generally not too uncomfortable to get, and often we can make a clear diagnosis. But sometimes they miss the best part of the lymph node, or they biopsy it and we see only scar tissue. And then we have to ask for another biopsy, sometimes another needle core biopsy. Sometimes we try and get the full lymph node out if we can. So pros and cons to each of these types of biopsies. The worst type of biopsy, and one we don't recommend as a hematologist, is doing a fine needle aspiration. It's really not appropriate to make a lymphoma diagnosis. This is often done by a surgeon in their office. It's a very fine, tiny needle that they'll stick into a lymph node and aspirate out some cells, basically. You can see that here in the picture. These are all different types of lymphocytes and other cells, but not in, you can see it's not in the normal architecture of the lymph node. It's just taking out individual cells, and lymphoma diagnosis really requires the lymph node to be in the original structure so that the pathologist can look at how they're interacting with the other cells. This fine needle aspiration is very good to diagnose other types of cancer, like breast cancer or squamous cell carcinoma. They can make that type of diagnosis with a FNA or fine needle aspirate, but lymphoma is very challenging. So we don't recommend that. Sometimes an ear, nose, throat surgeon who's seeing you for the first time might do a fine needle aspirate in the office and then immediately book you for a core needle or excisional biopsy if the fine needle is not diagnostic. So sometimes people end up getting both. When you have your tissue biopsy done, it's very important to ensure you get your pathology read at a center that has an expert hematopathologist in lymphoma. Because there are so many subtypes of lymphoma, you want to make sure not only that you have a good piece of tissue sent to the pathologist, but that you have a pathologist who's very familiar with these different types of lymphoma. You don't really want somebody saying funny looking cells correlate clinically. You really want them telling you exactly what's going on, and you really want to have a good relationship. I email and text with our pathologists all the time about results and asking them questions, and you really want to have that rapport with them and have them be able to tell me, like, look, I really can't tell what this is for sure. I think you need to do another biopsy, because you don't want to start off on the wrong foot with a not clear diagnosis. So Hodgkin under the microscope, I already showed this slide, but just to remind us in a cartoon version what normal cells look like and what abnormal Hodgkin cells can look like. They often talk about how Hodgkin cancer cells look like owl's eyes, and you can see here these at the top is an actual picture of a Hodgkin cell from a biopsy, and you can see obviously the owl's eyes and the similarities there. So this cell that we show at the top is that classic Hodgkin Reed-Sturberg cell. This is not meant to show in detail, you'll be able to see the detail here, but just to get an idea what the pathologists are looking at. This would be a typical panel of tests that they would do on a lymph node. And these tests take time to run, and often kind of multiple series of what we call staining, where they stain the tissue, these brown spots, for different markers to try and figure out which type of lymphoma it is. The top purpley looking one is 2 arrows here that's pointing out the Hodgkin cells. And then the pathologists say, okay, this looks like Hodgkin, but now I need to do these special stains. So they did staining for a marker called CD30, PAX5, CD15, and these ones classically mark only the large Hodgkin cells. And you can see the interesting thing about Hodgkin lymphoma is that although the lymph node or tumor mass may be moderately big, the number of actual cancer cells within the lymph node might only be 5 or 10%. And then the rest of these blue cells here are all inflammatory cells. So that's why sometimes Hodgkin, more commonly than other lymphomas, need more than one biopsy, because if you do especially a needle biopsy and you're not picking up enough of these Hodgkin cells, you're going to have a non-diagnostic result and then have to have it done again. This CD3 stain down in the bottom left is showing a lot of brown spots, but these lymphocytes are all the normal inflammatory lymphocytes, and it's the Hodgkin cells that are the minority in the other stains you see here. So just to get an idea as the challenges the surgeons and pathologists and us can have if you don't have that good piece of tissue. So how lymphomas grow. Now, nothing is perfect, but in general, Hodgkin lymphomas tend to spread from one lymph node directly to another. So in this picture, most commonly a Hodgkin lymphoma starts in the neck and then might spread to the armpit or chest. Where non-Hodgkin lymphoma, more commonly you'll see lymph nodes down in the groin, up in the neck, and in the armpit. So this is called contiguous growth, meaning it's growing from one spot directly to the other, where this would be non-contiguous, where it's growing kind of just randomly in different spots of the lymphatic system. That can be a hint to what's going on, but it still doesn't tell us for sure. Really, that tissue is the most important. The other features with Hodgkin versus non-Hodgkin, again, these are all just generalities, not an exact science, but in general, Hodgkin average age is younger at diagnosis. And we usually see what we call a bimodal age distribution, meaning we see people who are quite a bit younger in their 20s, and then we see people who are quite a bit older, like over 60 or 70, whereas non-Hodgkin, the median age of diagnosis is generally 60. We talked about the direct spread versus the multiple remote regions with non-Hodgkin. Hodgkin is more likely to be early stage diagnosis and non-Hodgkin later. And that's typically because Hodgkin often starts in the neck where you can feel the lymph nodes. Other organ involvement outside the lymphatic system is rare with Hodgkin and more common with non-Hodgkin. As you can see, treatment options are quite complicated for both, but they're definitely not the same for these diseases. So after you know for sure what your diagnosis is, the next thing you want to know is what stage of lymphoma am I? And so this diagram is a bit colorful, but the green dots are normal lymph nodes. The blue dots are Hodgkin lymph nodes. The orange line is your diaphragm, what separates your chest and your abdomen. And then the blue, these are your lungs and your livers, the pink. So stage 1 is when you have lymph nodes with Hodgkin in them in one area only. That could be in any of these areas, but there's nowhere else. So stage 1 is one area of lymph node only. Stage 2 is when you have 2 areas of lymph nodes. You see the 2 areas of blue lymph nodes in the neck on the left side or right side, I guess, depending on how you want to place the person, that are involved, but they're both on the same side of the diaphragm. So this would be stage 2. Even if you had 3 or 4 areas of lymph nodes involved in the chest region, that would still be stage 2. Once you get to having lymph nodes in the lower abdomen or below the diaphragm, that becomes stage 3. So lymph nodes above and below the diaphragm that are involved is stage 3 Hodgkin. And stage 4 is when you have another organ involved that is not part of the lymphatic system. So that would be your liver or your bones. That's not your bone marrow. Or actually, even if your bone marrow is involved, we would call it stage 4, as that is the lymphatic system, but that would upstage it. So that's the general staging. So how do we know where your Hodgkin is? Most people, the first scan they're going to get is a CAT scan. And a CAT scan measures the size and shape of lymph nodes. And you can see from this picture with the red circles and the red arrow, they're depicting areas of significant lymph node enlargement in a patient. In both armpits and just below the liver, there's a very large lymph node mass just below the liver where that arrow is pointing. The follow-up scan shows that those lymph nodes are gone. The green circles are showing where those lymph nodes used to be and are now gone. So CAT scans are very good to give us size and shape and location of lymph nodes. But if you have Hodgkin lymphoma, you're always going to get a PET scan after your CAT scan. And a PET scan is showing size and shape of lymph nodes along with how bright they are or how metabolically active they are. There are certain things that mark as bright, or in this picture, it's black. That is normal. So that the heart and bladder are pretty much always normally black. But in this first patient, you see in stage 1, they have one bright lymph node in the right side of their neck. Their tonsils are also lighting up, but that is probably not significant. In the stage 2 patient, you can see they have their right and left neck involved and the middle of their chest involved. And stage 3, you can see they have the right neck lymph nodes involved, and this arrow down at the bottom showing that there's a lymph node in the left groin involved. And this patient who's stage 4, who has lymph nodes in most areas above and below the diaphragm, and there's some spots in the liver there. So this is the gold standard for staging is a PET scan for Hodgkin specifically. We used to do bone marrows in everyone who had Hodgkin's when I first started working many years ago, but we stopped doing those about 5 years ago as the PET scanner is so sensitive to pick up bone marrow involvement. So it would be not super common to do bone marrows for staging in Hodgkin anymore, unless somebody had very low blood counts or another reason that you really wanted to do that test. Prognosis. So when you're diagnosed with cancer, the first thing people are going to think is, how is this going to affect my life? And what is my chance of getting this cured, or is this curable? As cancer is a scary thing. And, you know, we throw a lot of different words around and language around. So just to go over a little bit about the prognosis language. So we say when you're done treatment, you're in complete remission if your PET scan is completely normal post-treatment. That's called complete remission. That means we have very good control, and we can't detect any active disease. Cure is when we say, you know, your disease is gone forever and it's, you know, highly unlikely to ever come back. So those are slightly different. Complete remission, we would call as soon as you're done your treatment, but we probably wouldn't say you're cured until you're a couple of years out from that remission to make sure it hasn't come back. Relapse means your disease comes back after a state of remission, and refractory means that your disease never went into remission even after your treatment, so that there's still active disease at the end of your treatment. So those are the things that we're thinking about when you're done. So Hodgkin lymphoma was really one of the first cancers that was realized many, many years ago. You could cure with radiation and or chemo. And since then, and we're going to talk about treatment in a little bit, it's always been felt to be a quote unquote good cancer to have because it's so highly curable. And that is true, but I definitely don't minimize it. It's still cancer. You still have treatment. There's still uncertainties. And we do have to be cautious and make sure we're treating you appropriately. So when we talk about staging, we mentioned early stage disease, and that's also often called limited stage disease. So that's when you're stage 1, so one area, or stage 2, so all the disease either above or below the diaphragm. And A, meaning you don't have any of those fevers, drenching night sweats, or significant weight loss. So patients in that stages are called limited stage Hodgkin, and the cure rate in all of those people is greater than 95% or greater than 90%. And in the best limited stage, it's greater than 95%. So the chance of curing is very high. Lower stage means you need less treatment than a more advanced stage. Limited stage or early stage disease is further divided into favorable early stage or unfavorable early stage. I kind of don't like how that's labeled, because anytime you call somebody unfavorable, it sounds very bad, but it actually isn't bad. It's just a way to stratify further early stage disease, because unfavorable early stage will receive more treatment than people who have favorable early stage. And that's why we differentiate that. So if you have unfavorable, limited, or early stage disease, so stage 1 or 2A, There's a few different ways we can stratify this. So I've put all the factors down here. It depends on which clinical trials we look at. But generally, if you have a very large mid-chest lymph node, if you have fevers, night sweats, or weight loss, if you have an elevated blood test called an ESR that's above a certain level, or if you have more than 3 or 4 nodal areas involved on the PET scan, so areas where the lymph nodes have Hodgkin in them, or some studies used an age above 50. If you have any one of these with early stage disease, then you're considered unfavorable limited stage, and you need a little bit more chemo than someone who has none of those things. And we'll talk about that when I get to treatment. So if you have advanced stage disease, that is very scary for people. When I tell people they have stage 3 or 4 lymphoma, I try and, remind them that lymphoma is quite different than lung cancer or breast cancer or something that is not curable at those stages, where lymphoma is still curable at these stages. And the cure rates are as high as 70 or 80% or higher for all advanced stage Hodgkin. Again, if you have higher stage Hodgkin, you're going to require more treatment than somebody with early stage. We do use a risk score for everybody who has advanced stage Hodgkin. I give those numbers to patients if they want them, but otherwise I use them more for my knowledge. And we use this risk score called the International Prognostic Index, which looks at this is based on looking at a big number of patients and who did better or worse. So if you have any of these factors, they slightly reduce your chance of cure. So if you have only one of these factors with advanced stage disease, so say you're male, you can't control that, but let's say you're male, that gives you 1 point on this scoring system. And if you don't have any of the other ones, your average chance of remission at 5 years is 88%. If you have every single one of those adverse factors that I've listed there, and you get a score of 7, then your chance of being remission at 5 years drops to 70%. Now that's an average. These are all averages based on studies. I still can never tell a patient exactly what their outcome is going to be, which is the most stressful thing about cancer, is that we don't know exactly what's going to happen. Even the highest risk patient can be cured. And I've certainly seen that many, many times because these numbers are still very reasonable for an advanced cancer, although not perfect, which we'd all like them to be perfect. So prognosis-wise, Hodgkin lymphoma is highly curable cancer, even at advanced stages. But it's still a cancer. So we need lots of different treatment options and research to try and make sure we're doing our best here. So treatment options for Hodgkin. Unfortunately, there are no pills right now for Hodgkin lymphoma, but I just liked the picture. They are all injection medications. So as I mentioned, it is highly curable. And the goal, because it's so highly curable and has been for so many years, a lot of the research in recent years has focused on trying to reduce treatment and maintain cure and reducing long-term side effects of treatment, because now so many patients live forever, not forever, but live a normal life after Hodgkin. We have to be aware of potential later treatment side effects that may occur. So because of that, treatment has actually been reducing over the years with Hodgkin. The different types of categories of treatment would be chemotherapy, which uses drugs to kill lymphoma cells, radiation, which uses radiation to kill lymphoma cells, immunotherapy, which is just a general category of newer targeted drugs that find and kill lymphoma cells more directly. And then transplantation, which are stem cell transplantation or bone marrow transplantation, which is infusion of healthy cells or bone marrow to help restore its lymphatic system in a healthier way. So the first 2 categories are generally used for newly diagnosed Hodgkin, and the second 2 categories are generally used for relapse Hodgkin, although in the last year or so, we now have immunotherapy available for newly diagnosed Hodgkin in some cases, which we'll get to. So a bit of timeline for treatments, and then I'm going to talk about these different treatments and then leave some time for questions still. So radiation was first discovered for Hodgkin lymphoma way back in 1901. So like a long time ago. And of course, it was considered probably a miracle back then that they could treat a tumor with radiation and then have it potentially never come back. ABVD chemotherapy, each letter is a name of a different chemo drug. That was invented and implemented in 1973, which was before I was born. And it's the same treatment we are using now. So that treatment has been so effective at Hodgkin lymphoma, it's been hard to beat. Escalated BACOP is a more European German chemo regimen that we have used more in North America in the last 5 years or so. That's been around since the 1990s. It's a much more it's a much stronger chemo regimen that has more late side effects. Brentuximab is one of the immunotherapies and was the first new treatment approved and FDA approved for Hodgkin lymphoma in 40 years. So we'll talk about that a little bit. That was initially approved 2011 for relapsed Hodgkin lymphoma. And then another new immune therapy called nivolumab was approved in 2016 for patients who relapsed after having brentuximab immunotherapy. And then there was a few other indications. Brentuximab got approval in 2015 for post-auto transplant maintenance. Pembrolizumab, a similar medication to nivolumab, was approved in 2017 for relapsed Hodgkin. And then again in 2020 for any relapsed Hodgkin. And then most recently in 2018, brentuximab was approved for newly diagnosed Hodgkin stage 3 or 4. So again, that's the first new treatment for newly diagnosed Hodgkin in over 40 years. And I don't think of it as a failure of treatment for Hodgkin's. I just think they did so well with the initial treatment. It was really hard to improve upon that, but there are still improvements being made. So overview, so Hodgkin treatment is very complicated in terms of how to choose the best treatment per patient. It can vary slightly by treatment center, and they all may be appropriate treatments. The standard treatment would be to receive chemotherapy, plus or minus immunotherapy for advanced stage Hodgkin, plus or minus radiation. It depends on the situation. For limited or early stage disease, you're going to have a lower number of chemo cycles and more likely to receive radiation. Because radiation is good for focal disease. For advanced stage disease, so stage 3 or 4, you're more likely going to get a higher number of chemo cycles and less likely to get radiation. Again, individual situations may change that. The standard chemotherapy for Hodgkin in North America and a lot of other the world is something called ABVD chemotherapy, adriamycin, bleomycin, vinblastine, dacarbazine, given 1 day every 2 weeks. 1 cycle is 28 days. And for the earliest, best prognosis, early favorable Hodgkin, you're often getting 2 cycles of that. So 2 months of treatment. Whereas for advanced stage, you're more likely you're going to get 6 cycles. And then anywhere in between that, again, depending on your risk of your disease. And a lot of that may depend on how your PET scans look after you've received some treatment. So this, I just give the range there because it is quite variable depending on your stage, your risk prognosis, and what your first PET scan looks like. And we usually do a PET scan after your first 2 months of chemo to take a look at how things are going. And we really want that PET scan to look quite good after 2 months of treatment. The alternative chemotherapy for advanced stage disease would be something called escalated BACOP, which is a more complicated and much more intense chemo regimen. You have to be cautious. We generally wouldn't give this to somebody over 60 or 65, or if they have health comorbidities because of the strength of this. Again, this is more widely used in Europe and mostly in Germany. I think in Canada, we usually reserve it more for advanced stage, high-risk Hodgkin, or if your PET scan is not good enough after 2 cycles, we would consider escalating to this chemo regimen for your last number of treatments. So relapsed Hodgkin's, again, treatment can vary by treatment center a little bit, how old you are, your health history. You could get chemotherapy different than the first time, plus or minus immunotherapy, plus or minus radiation. A younger, more fit person, and again, we don't do anything by an exact age, but in the past it would be less than 70, you get chemo followed by something called an autologous stem cell transplant. And if you were older and less fit, meaning less health issues, more health issues, or you didn't have a good response to your second line of chemo, then you'd receive immunotherapy. I won't go into a lot of detail about an autologous stem cell transplant or also an auto stem cell transplant, but this is a way that you can cure relapsed Hodgkin lymphoma in about 50% of patients who have relapsed Hodgkin lymphoma who are eligible to receive this type of bone marrow transplant or stem cell transplant. It's a good option to try and cure them. And generally, we're going to give the patient 2 to 4 cycles of chemo that you haven't received already. And then if you've had a really good response on your PET scan to that chemo, we do something called a stem cell collection through the blood, not through the bone marrow. So there's no surgery or anything involved with this. And the stem cells are collected and frozen, and then you receive very high dose chemo as an inpatient, and your stem cells are reinfused. So this type of bone marrow transplant is really a way for us to give very high dose chemo to try and eradicate any lymphoma left in your body is the goal of this. And so this is standard second line therapy for relapsed Hodgkin lymphoma in somebody who's fit enough to receive this treatment. And the intent is still to potentially cure the Hodgkin. Immunotherapy, again, you could have a whole talk just on one of these drugs. There's so much data on them, but they're protein drugs that help kill Hodgkin cells directly, often in the form of what we call a monoclonal antibody, which targets the Hodgkin cell directly. So the three main drugs we have approval and funding for in Canada now are brentuximab vedotin, nivolumab, and pembrolizumab. Brentuximab vedotin is an antibody that attaches to the CD30 on Hodgkin cells. And in this diagram below, the HRS is the Hodgkin-Reed-Sternberg cell, the blue cell. And you can see the pink box I have near that, the little Y-shaped thing is the drug brentuximab. And so that attaches to your Hodgkin cell directly and goes inside it and kills the DNA of it basically, and the cell dies. Whereas nivolumab or pembrolizumab are in the same category of medication. They affect how your Hodgkin cell is recognized by your immune system. So it basically helps your T cell, immune cell, recognize your Hodgkin cell and kill it, is basically how that drug works. So these drugs work totally differently than chemotherapy, and they're very targeted to the disease. So brentuximab is IV, given every 3 weeks for relapsed Hodgkin. Oops, sorry, I didn't mean to move that. There was a big, what we call a meta-analysis study, looked at this drug, and any response, about 61, sorry, I keep hitting the proceed. The 61% of patients have had some response to the drug, and about 38% a complete remission. But unfortunately, with relapsed Hodgkin, this drug will never cure you. So none of the immune therapies will cure the Hodgkin. The only chance to cure relapsed Hodgkin's is with a bone marrow transplant. And so this drug has recently, in the last year or so, been approved for newly diagnosed stage 4 Hodgkin lymphoma and funded in Canada. So that's given along with our standard chemo for 6 cycles. And this study, people thought it would have more of a benefit, but the 6-year follow-up showed about a 5% benefit in overall survival for the patients who received brentuximab rather than the standard ABVD combination. So you can see the 5-year remission rates were 93% in the patients who got brentuximab with AVD and 89% in patients who got ABVD. So both very good numbers, but it was approved based on this 5% improvement. Nivolumab and pembrolizumab. Nivolumab is for relapsed Hodgkin, given IV every 4 weeks until progression. Response rates around 69%, complete response 16%. On average, people are on drug about 1.5 years. I certainly have patients who've been on this drug much longer than that, but similarly could be on shorter than that, depending on your response. Pembrolizumab, a drug in the same category, given IV every 6 weeks. Again, response rates sort of similar. Again, these drugs help control difficult to treat Hodgkin's, but are still not a cure for the disease when it's in that relapse state. So what treatment might be coming? There's been a new study looking at nivolumab with newly diagnosed Hodgkin's with AVD for patients over 60 that's had very promising results and might even be better than the brentuximab results, but we'll have to wait and see. That was recently presented in preliminary format at our recent major conference in the States. CAR T-cell therapies, if people have heard of that, this is special immunotherapy that is approved for some types of lymphoma. It's in the early stage trials for Hodgkin, so not coming anytime soon. There are new PD-1 antibodies that are in early trials, a lot of combinations of the new agents. So now that we know these new agents work so well, they're being moved to the newly diagnosed categories to be tested to see, can we cure more people up front and prevent those relapses? So clinical trials are always important. It's a good option to explore relevant clinical trials at your center. The main Hodgkin clinical trial we have in Halifax right now, and I think a lot of centers in Canada have, is for relapsed Hodgkin lymphoma, looking at our standard chemotherapy regimen versus getting 2 immunotherapy drugs and then going to transplant. So we're looking to see if we can get people in better remissions with the new immunotherapies before transplant. We don't know the answer to that. That's why I was studying it. Sorry, I'm trying to advance here. There we go. I'm not going to go through all the side effects of treatment because it can vary and it's a long list and really out of the scope of this talk. But the general chemotherapies, ABVD and escalated BACOP, are going to be the ones that can cause hair loss, more likely nausea or low blood counts, where the immunotherapies don't cause hair loss, but they can cause some other immune-related issues or organ troubles. So definitely talk about that with your individual physician anytime you're changing treatment. Follow-up post-treatment is very important. In general, I think most centers would do a PET scan 4 to 6 weeks after your last treatment to determine if there's complete remission, i.e., is there no detectable disease. Regular follow-ups, most centers will do for at least 2 years, every 3 to 6 months. As you get further out, your follow-ups become less frequent. Most centers will not do routine scanning. There's been studies done to show routine scanning doesn't pick up significant relapses earlier than regular surveillance, meaning history, physical laboratory investigations. We certainly would have a low threshold to do a scan if there was any concern at a follow-up or between a follow-up. And most specialty clinics will sign back to the family doctor and label as cured somewhere between 2 and 5 years post-treatment, again, depending on treatment center. So the future of Hodgkin, we really obviously want to keep Hodgkin very curable, but reduce both short and long-term side effects of treatment. A lot of the research will be focusing on difficult to treat patient populations, patients who are very elderly, hard to tolerate some of these chemo regimens, and we want to maximize their cure, but minimize side effects. People who have more resistant disease need new therapies. And so lots of research going on into the disease biology of Hodgkin to help develop new agents, which will be very important. So I was trying to rush through in the end because I know I want to leave time for questions. Yeah, so I don't know if that's what we'll do now, the Q&A.
Yes, we will. That's perfect. So thank you very much, Dr. Keating. That was a wonderful presentation, a lot of relevant information. So as just was mentioned, it is time for the Q&A period. If you haven't already done so, please use the Q&A box and input your questions. We due to the large number of participants, we may not get to your questions, but they will be answered as follow-up. And someone will connect with you in the coming days. So I guess we'll start with the very first question that came in, and this was, are there any significant differences between pediatric and adult Hodgkin lymphomas in terms of causes, treatments, symptoms?
Yeah, so as a disclosure, I'm not a pediatric hematologist, so totally different specialty, but I've done a month of pediatrics in my training years ago. So the presentations would be very similar because it's the same disease organ, and the causes, I'm not sure. I don't think they know much more about pediatric causes than we know about adults. The treatment is definitely quite different. And again, I don't know their regimens, but I know their treatment regimens are different than ours, and they're more intense because children can withstand better or more chemotherapy side effects than adults. But I'm not super familiar with the exact regimens, but it is not the same treatment that we use in adults. It would be similar, but not the same. Yeah.
Wonderful. Okay, perfect. And as a kind of follow-up, I guess, is please explain the 5-year survival rate and what that actually means when we're talking about survival rates.
Yeah, so there's different ways to measure outcomes in cancer. One is something we call progression-free survival. That means you're alive and don't have your lymphoma at the time of follow-up. So if a 6-year follow-up overall survival is 95%, that means 95% of people who are on that clinical trial are still alive at 6 years. That's a good number, but a certain percentage of those may have relapsed. So overall survival is how many are alive at the follow-up time, and progression-free survival is how many are alive without their lymphoma. because a certain percentage of people will be alive but relapsed and undergoing further treatment, or have undergone further treatment and a transplant and are now in remission again. So I don't know if that fully answers the question. And those numbers that we come up with, or the risk scores, are all based on large clinical trials. The clinical trial that approved that brentuximab in advanced stage newly diagnosed Hodgkin had 1,300 Hodgkin patients in it, 600 in each arm. One arm received brentuximab with chemo, the other received just the chemo, or standard chemo. So that's kind of how those numbers are come up with, are brought to us in research.
Great, thanks very much. I think a lot of people sometimes have a hard time understanding the statistics that are presented for for all these diseases. So it's great to hear that explanation. So we've had a couple of questions about refractory Hodgkin lymphomas. And for patients who are refractory, is there anything that can be done to prevent relapse? And what are the theories on why treatment does not work for those patients?
Yeah, and this gets into probably there being like, although we say everything's not everything, but if you have Hodgkin lymphoma, that's one diagnosis. But in reality, there's probably small intricate differences in the biology of the disease and the genetics, in exactly what the genetic change was within their Hodgkin cell that make it more susceptible or more resistant to our standard treatments. The rarest subtype of Hodgkin lymphoma, the lymphocyte deplete, does have worse prognosis than the other subtypes. It's more likely to be advanced stage, more likely to be resistant to treatment. So we don't know, we know in theory why that would be, but we're not at the place in science and medicine yet that it's so individualized that we can figure out those things to get around. I mean, who knows in the future how much more detail we're going to be getting on things to and understanding that biology. So we don't really know. I see some of the questions there. Why don't immunotherapies cure Hodgkin? Well, we don't even know enough yet. Like maybe they do. Like we have some patients still in long-term remission who've been on immunotherapies so long, and they've been in remission so long that the physician actually says, well, do you want to try and stop this and see what happens? And those patients are still being followed because these are still relatively new treatments. So in general, there's been no consistent report of long-term remission with immunotherapies. But there are some patients who will get extremely long remissions with these diseases, with these drugs, and be in remission with no detectable disease. I had a patient I saw yesterday who's been on pembrolizumab for 4 years, 5 years, who's the third time relapsed and is in complete remission. So there's a lot we don't know necessarily with the longer term and how are some people actually getting cure and others, their disease is just becoming resistant to the treatment. It has to do with the receptors, these PD receptors, and are they upregulated or downregulated, and what your cancer does with it. But the short answer is it's because these cancers aren't all the same between people. And so they don't exactly all respond exactly the same to the drugs. But there's a lot we don't know with that yet.
Of course. And I think a somewhat related question to that is what we're looking at the long-term effects of the treatments that these patients are on, and how that looks, down the road. What do we see in that?
Yeah,
respect?
so the biggest concern that the most treatment changes have been made has been with radiation. So radiation is a good treatment for Hodgkin. It treats it well. But in the past, radiation was the mainstay of treatment for Hodgkin, like remote past, like even before I started working around 2011. Like they would give high doses of radiation to large areas and they'd cure people of their Hodgkin. But then 10, 20 years later, you start seeing women coming with breast cancer, heart disease, valve problems, vascular disease, because the radiation accelerates hardening of the arteries or increases the risk of a second cancer. So radiation over the years with Hodgkin has been reduced in dosing, reduced in the area given, and all the recent studies have shown that we're maintaining cure with those changes, but reducing long-term side effects with those. So I used to be way more radiation, now it's way less. They've done a ton of studies looking at removing radiation altogether, like saying, do we really need it? Like, can we just give ABBD or just give escalated BACOP? But all of those studies say that if you don't give radiation to limited stage Hodgkin, you're losing about a 5% remission, like progression-free survival. So we do have those talks with patients to say, look, like you don't have to get radiation after your 2 or 4 months of chemo, but this is what your risk is of relapse if you do or don't get radiation. And this is the risk of getting radiation, short and long term. So those discussions are important for depending on the area of radiation, depending on the age of the patient and then that sort of thing. So some centers may do more radiation, some less, depending on those, how they interpret the data as well. But radiation is still important for early stage, especially. And for the other treatments, there's late risk of second cancers with chemo, much higher with the escalated BACOP than with ABVD. It's quite low with ABVD. Fertility is a problem with escalated BACOP, that strong chemo, not with ABVD. Fertility is preserved. And then chemotherapy, the long-term side effects otherwise are minimal. Like you could have risk to cardiac troubles in a small percentage of people, or risk of neuropathy would be the other common thing. Pins and needles, fingers and toes. Yeah, so just trying to minimize those things. And one drug, sorry, there's a lot to talk about, called bleomycin, the B in ABVD, was removed in that newest regimen where brentuximab is added, the immune therapy, because bleomycin has a risk to lung toxicity. So we're trying to get rid of that drug if we can. Yeah.
Very good. And we had a question come in while you were answering that about the linkage to other secondary cancers and what other cancers is Hodgkin lymphoma related to?
If we mean, so once you have one lymphoma, although often people are cured and they never have it again. Once you've had one lymphoma, your risk of getting another lymphoma in the future is higher than the average person, because your lymphatic system has already been shown that there may be something not perfect about it, that has happened a first time. But if it's a treatment-related cancer, like from chemo or something like that, which are rare, these aren't common things, something like acute leukemia, so another blood cancer, or myelodysplastic syndrome, another blood cancer, can occur if you've received chemotherapy before. Again, we're talking 1-2%. We're not talking about high percentages of people.
Wonderful. So I think we have time for just a couple of more questions here. And so one actually just came in. What are preferred options for maintenance therapies following stem cell transplant, and what treatments following relapse after an autologous stem cell transplant?
Yeah, so if brentuximab, that CD30 monoclonal antibody that has attached chemo, that is approved and funded in Canada now for maintenance post-auto transplant for patients with high-risk Hodgkin lymphoma. And there's a list of things that was the way the clinical trial was done, and that showed an improvement in remission time for patients who received maintenance post-transplant versus not. So that is approved and funded based on a clinical trial from like 2015. And I think we've had that here since at least 2018 or 2019. It wasn't even approved the last time I did this talk in 2018. So that is newer, the last kind of 4 or 5 years. If you've relapsed post-autologous transplant, it depends on your age and fitness, but you're really thinking of brentuximab if you haven't had it yet. And if you've already had brentuximab, you're thinking about immunotherapy. So pembrolizumab or nivolumab would be standard, versus seeing if there's any clinical trials in your area that may be useful to you. Depending on your age, allogeneic stem cell transplant, which is a transplant from somebody else, can be considered. But this is usually a last resort sort of treatment for Hodgkin, as the side effects are high, and it doesn't always work that well. The immune therapies would be better to use as long as possible with that. I was going to say something else, but now I forget. That's it. Yeah.
Perfect. Okay, and so I always like to end these on a very hopeful note and ask a question about what do you think the next 5 to 10 years look like for or beyond for Hodgkin lymphoma prognosis and treatment?
Yeah, I think we're going to see less chemo and more immunotherapy up front. So whether that will be with brentuximab or the PD-1 inhibitors, nivolumab, it'll be interesting to see how those trials play out that are underway and kind of being reported already. Also, I'm hoping to see better treatment in relapsed Hodgkin lymphoma pre-transplant, often in patients who are refractory to treatment, meaning they haven't gotten to remission. We don't really want to use chemo again. We'd much rather use immunotherapy pre-transplant. I'm hoping that will be standard. And also, I didn't touch on this, but in terms of deciding if somebody's in remission or not, sometimes a PET scan, it's hard to say for sure if they're in remission or not. There's false positives and false negatives. And there's been a lot of research on circulating tumor DNA. And most clinical trials now have that as part of them, where they are actually looking for tiny particles of tumor DNA in your blood. And that helps us determine with the PET scan, are you in remission or not? And what is the chance you're going to relapse based on those results? That's not standard of care yet. That's only clinical trials, but that will be coming. That's pretty standard in all trials for lymphoma, all lymphomas now. So I think that's kind of in the closer, those are all the things that are in closer. Longer term would be nice to get, if CAR T-cell therapy starts working for Hodgkin and we have bigger studies, that would be a nice other avenue for relapse patients.
Perfect. Thank you so much, and so thank you very much again for your time today. Your insight and expertise is very valuable to us. I'm sure everyone listening will agree. We do have a couple more slides just to get to at the end, so please bear with me for the next 2 or 3 slides. So you can go to the next slide for me, please. That'd be great.
Oh yeah, sorry, I'm doing controlling.
Yes, you're in control. So we'd also like to thank our sponsor, Segan Canada, for their support in making these events possible. Next one. Please remember that we are here to help you. You can reach us by email, by visiting our website, bloodcancers.ca, or by calling us toll-free. And there will be a short survey sent to all participants after this presentation. Please take a moment to respond, as it helps us plan for future events. Thank you all for being with us today, and thank you again to Dr. Keating for her expertise on this matter, and take good care of yourself. Thank you very much. Bye.